Okay, I'll just share my screen and make sure that you can see. This is always the worst part. All right, can you see it?
Yes.
Good. All right. Okay, so thanks to Elisa for organizing this. I can't believe either that it's year 5. And also the ALD Alliance and all the participants from yesterday. We always have really good discussions, and we do miss seeing everybody in person, obviously, but I guess this is the next best thing. So I'm gonna go over a summary of the things that we discussed, and per DOH, I'm just summarizing the discussions from the roundtable, and I have just speaking on behalf of myself and the participants. Oops. Okay. So we had about 60. There were times where it was 66 or so, and then sort of dropped off during the call, but about 60 people participated in the roundtable yesterday. So that's actually a benefit of this type of format, because you have more people who are able to join in, and you get input from a broader group of people than those that can make it to New York. So it's a double-edged sword. So the states that are here are the ones that actually presented data during the call, and helped Elisa fill in a spreadsheet that we had put together to kind of look at the global ALD effort across the country. And it's of interest, as Elisa said, we began screening in New York December 30th, 2013. And so our oldest screen positive boys are now around 7 years of age. And the first ones that were detected are just turning 7 years old. As I said, there's many others that participated besides the states listed here. We're also approaching 5 years since the recommendation to add ALD to the recommended uniform screening panel was approved. So this is a big milestone for the ALD community in general. So I just put together, this is a running group of maps. So every year the talk gets a little bit longer because we have another year to add. So in the beginning, when we started this, it was 2018 was the first time this map, I think, was available. And there were only a few states that were screening for ALD at the time. So nice look back, not that long ago, 3 years ago in 2018. And then 2019, we had a few more states join in. And then last year, again, it's kind of confusing because last year's 2020 doesn't sound that last year, but we did this fresh into 2020 last January. We were up to 18 states. And as of this year, 2021, we have 20 states that are screening for ALD. And of interest, that covers about 61% of the babies who are actually born in the United States. So we kind of crossed over the half of births. We have a lot to go, but we've made good progress. And as Elisa said, this is her mission. She is continuing to advocate for ALD screening on a state-by-state as well as nationally. And this map she sent me this morning shows the status of the country related to ALD. And so here, the green states are the ones that are all screening for ALD. We have several states shown in red that are starting testing this year. And we have the blue states are the ones that are in the process and looking at screening for ALD. And then Massachusetts is a pilot program. However, its uptake is quite high, and so we typically count them as screening the whole population. So based on the data that we were able to collect, and these are approximations, I don't want anybody to take home and say, here's the incidence, as truth, but this is the data that we're able to collect so far. So if you look at just males that were screened, the highest frequency or incidence rate is 1 in 11,000 births. The lowest is 1 in 60,000. Now, you have to temper this with, when you look at the number of babies that are screened in a given state, how long they've been screening and what that denominator is that impacts these numbers, because we're looking at rare diseases. In females, it's close, about 1 in 10,800. And then in the low is 1 in about 80, almost 82,000. And then overall, when you combine male and female frequencies, and this is just ALDs, it's about 1 in 7,200. And as the high kind of range, and then the low range is 1 in 40,000. So I tried to calculate referral rate based on the data that we were given, which included all the confirmed males, confirmed females, kind of other diagnoses and the pendings that we had. And last year, this number was about 1 in, I think, 7,200. This year, it's 1 in 10,000-ish. It's definitely less than 10,000 because I'm sure we had incomplete data in the pending cases. So it probably hasn't changed a whole lot from year to year. But the question is why we have this variability across, when you look across the country. Maybe it's just plain old numbers. We're looking at rare events. We look at different ethnicities, different kindreds across the country, and you're trying to get a good denominator. Even though we have 6 million, these are still fairly rare events. So maybe it's just a numbers game based on how many you're screening in a particular state and what your population makeup is. Another thing that we spend a lot of time talking about, not only at the roundtable, but in the ALD screening community in general, is that people are using different tests and different algorithms are used for screen positives and also for diagnostics. And so how we define a case in ALD screening is very important. And as Joe's work has shown, and other states that are participating in his study I'll talk about, states use different cutoffs for the screen positives and then sort of what happens after that. And we see sort of a trend downward because New York started screening, we set a cutoff, then we send samples to another state. They don't want to miss anything that we said was positive, so they tick their cutoff down a little bit, and then it's an ongoing exacerbation of that. And so we want to try to avoid that, and we want to make sure we're obviously not missing a baby who has ALD, but we also don't want to send a lot of parents, for serial MRIs and all the downstream effort that's needed. And so we are trying to figure out sort of the different things that we have control of that we can fix, so that we look at reasons for the variability and actually be able to explain it. So this is an older study grant that we had from the CDC, and we talked about this last year, but the last 2 bullets here, and now Joe's in the process of preparing a manuscript from the work that was done by these various states. And also Joe was involved in a document on ALD screening from the Clinical Laboratory Standards Institute, which is, we call in the lingo, CLSI. And so a lot of downstream work from this funding, which was originally, put out to help states implement newborn screening for some of the newer conditions. And New York State has done a training workshop. We've done that through lab and follow-up training. And we've also, through our regional genetic networks back in the day, had an ALD only symposium back when ALD was first being added to New York State and then to the rest. So, we all agree that we need to harmonize, and the issue is trying to find out what we can control and things that we can change. And so one thing that we looked at was the variability in cutoffs, and does that explain the range of incident rates that I just showed you? So there's different ways that people can look at not only having like a frank cutoff. One way to look at this is look at a multiple of the median approach, understanding that different states use different methodologies to screen for ALD. And so just even though you're using different methods, maybe a number isn't quite the right approach. And so this is something that's looked at for some of our other conditions and has been done through the Iowa program. Stan Berberk has used this in other newborn screening conditions to see if we can normalize our data across different screening tests. Less than 1 in 10,000 infants screened are referred, and what's the outcome with that? This impacts the downstream diagnostics as well. Some states yesterday also reported pretty broad variability in detecting females. So some states have a pretty clean 1-to-1 ratio, or maybe a little bit of female excess in ALD screening, but there's some states that have almost like a 2-to-1 ratio, females to males. And so what is that variability? Like, why are we picking that up? Is that related to cutoff? Is it related to methodology? So that's another kind of area we need to take a look at. And also, people define false positives in newborn screening different ways. So some people will say if newborn screening picks up a Zellweger syndrome, that's a false positive for ALD. Well, it's not ALD, but we certainly impacted that family and let them know what was wrong with their child, since most babies with Zellweger have poor outcomes. And so how you define false positives and what the very long chain fatty acid values are they borderline? Is that considered a false positive? The definition of that is difficult. But actually, in reality, if you look, there's very few babies actually in that category when you use the false positive definition, such as a baby screened positive for ALD and did not have elevated very long chain fatty acids or some other condition that outcome in screening could describe. And I talked about cutoff creep. What are we detecting when we do population screening? Are there people walking around who have elevated very long chain fatty acids but do not have any sort of phenotype at all? And the big question is, will we ever be able to associate phenotype with a biochemical result? Will the biochemistry ever explain what the downstream expectations for phenotype are? And we already know that that's not necessarily true with the molecular, but the more data that we are able to compile, the better we could get a handle on looking at that. So we spent a fair amount of time yesterday still talking about case definitions. It's one of these things that is, Joe and I were just talking to have a chicken or the egg discussion. If you define a case in newborn screening, is that a case because it's a biochemical diagnosis, a molecular diagnosis, or a clinical diagnosis? And prior to population screening, we were left with sort of the clinical diagnosis. So either a family history or someone with an abnormality who then had downstream testing and then was positive for ALD. One thing that APHL has done, the Association for Public Health Laboratories, is with funding from HRSA, has a New Steps grant. And the website is there, it's open, you can take a look at it. And what we've tried to do is gather experts, both in newborn screening for ALD and other conditions as well, and then clinicians who also are expert, and come up with case definitions that we all can sort of agree on. And that I have some slides that show you kind of what that looks like. We need also to consider the different testing methods, as I talked about before. Some folks, Amy Gaviglio and Dr. Kemp from the Netherlands, have already started questioning about this and looking at it. We know that the CDC collects this information as part of their proficiency testing program, but due to the privacy agreements associated with that program, they can't release that information. But certainly it's sort of out there, and we can fill in. Stefan sent Joe and I a spreadsheet already that had a lot of this information filled in from the New Step site that we showed yesterday as well. And the other issue about the diagnosis and case definitions is the fact that very few diagnostic labs have newborn cutoff ranges. So they have cutoff ranges for children who are diagnosed with children that may be diagnosed with ALD once they're symptomatic, but in a newborn, they're either variable or they don't really exist that well. And so does that make a diagnosis variable as well? So Joe has done a lot of work in the interim, despite COVID and everything else going on in public health laboratories, and has spent a lot of effort in looking at outcomes and trying to evaluate those and writing a manuscript. And a lot of that has happened because of the work that was done from that CDC grant and the meeting that was held, and sustaining it with conference calls. You know, we're kind of going down the path to be able to maybe answer some of these questions. So because of his, because he's so well known in the United States regarding ALD screening, Joe was asked to spearhead the writing of an ALD document for CLSI. And one of the things that they really wanted to focus on, obviously, if a child is positive by newborn screening, has a known pathogenic variant, may or may not have a family history, but has elevated very long chain fatty acids and a high screen positive result, those children were, you know, there's really not a lot of argument about defining what they are, that they are ALD. But we're sort of left with the other kids who have borderline results. They may have borderline even results in newborn screening and or very long chain fatty acids. They may have a variant in the ABCD1 gene that's of uncertain significance, and they really don't have any known family history. What do we do with those children? How do we follow them and make sure that the family stays focused to look for signs and symptoms and make sure that they have the evaluations that they require in order to be able to do something to change the outcome. And so the CLSI document has a couple recommendations. It will be available at some point. It's in editorial review now, which is one of the last steps before it gets released. And one of the recommendations was to have another very long chain fatty acid determination done when the child reaches 1 year of age. There's also a recommendation to focus on matrilineal relatives and look at their ABCD1 variants and have very long chain fatty acid levels done on them as well. And I'll talk a little bit about an alternate test that may help in that effort as well. And then also take a detailed family history and, if necessary, have additional biochemical and functional testing of family members. There's this question of whether there is a family history or not. And one quote I liked from yesterday is Dr. Raymond said that it's not a family history until you make it one. So he talks about a case where there was no family history as they were told. However, the grandfather did have an abnormal gait, and so probably had AMN and never really had a diagnosis. And so you also have to be careful on whether you have a family history or not. So this is the New Steps website, and I did show this last year as well. It's changed a little bit, but they have case definitions for ALD males, heterozygous females, ABCD5 males and females, and then all of these other peroxisomal conditions, and then also obviously with a non-peroxisomal disorder. And again, this has a series of sort of check boxes that you look at to determine what the status is for very long chain fatty acids. Are there clinical symptoms, plasmalogen levels, if that's part of the workup, depending on the different conditions, what mutation analysis tells you, and any family history. And so this is a public health and clinical attempt to kind of bin families into one of these categories to help us assess what a true case is versus what is not, because that's really important in order to feed back to the newborn program so that we're finding the kids that are at highest risk for ALD and not finding a lot of children who will not experience symptoms related to ALD. And so we talked a bit last year and again this year about functional assays and the utility of those. And so these are available in the Netherlands and from Kennedy Krieger as well. One of the challenging parts of this is that it requires a skin biopsy. So it's a fibroblast assay. And you need to, skin biopsies aren't real pleasant, and they're not pleasant for little babies. So you have to kind of balance having maybe one skin biopsy and then preventing serial MRIs down the road. But, do you want to put your eggs all in one basket? Sort of how would you use that in practice? There's a sense that it may help in some of these borderline cases, and it may help with family members as well. But as Dr. Kemp talked about yesterday, he still sees sort of a gray zone with functional testing. And as you test more and more people with this, you are going to see that. And so one of the things to work on is refining the cutoff actually for the functional testing as well. Another thing that we talked about was whether it is useful to do a plasma or red blood cell C26 LPC, lysophosphatidylcholine marker in females to better define phenotype for them. There's still some work to be done in that area. And so that's kind of a newer area of investigation that we talked about a bit yesterday. And can we use expanded family testing and do these functional type assays? And will that help delineate the possibility of downstream sequelae in the newborn that we've identified? So can functional testing help with release a baby from follow-up as much as make a diagnosis? So Stefan doesn't sleep much, and he has his website, the adrenalleukodystrophy.info website. Last year, there were 109 variants. This year, there's 809 variants last year and 890 this year. So this is a growing live database that he updates regularly. And there's a lot of information besides looking at ALD variants or ABCD1 variants. And I have a picture here of kind of when you look into that mutation database, And what's kind of interesting is you can have entries here where it's clearly a pathogenic variant. It's been documented multiple times, and the functional assay data is available as well. You can also have cases where it's a pathogenic variant, but was only identified in a single case, but was thought to be deleterious. And then the bane of our existence is it's identified one time in a newborn screening program, and we really don't know what to do with interpreting that variant. So it remains a variant of uncertain significance for us. And it's sort of that creep about, is that really a variant? Does that family really have ALD? And again, that's kind of the whole reason we spend hours at these meetings talking about it, as well as offline. So when you look at ALD newborn screening by the numbers, I have here the numbers that were presented to us yesterday, and I collated all the state numbers. I don't have necessarily have permission to show state by state, so I thought it was good to look at kind of the global view. The numbers next to these in the teal color are from last year's slides. So this year we've screened over 6.6 million babies as of now. As of this year, we've found 268 boys and 252 girls, and the incidence rates are there for those numbers. And the incidence rates last year were 113 boys and 131 girls for the number detected. And then the overall incidence is shown here is 1 in almost 13,000 compared to 1 in 18 last year. We are, it's a challenge to always get the absolute numbers again, because we have cases that are pending and cases that are sort of open to follow up and pending differential diagnoses. And so this is sort of a snapshot right now of what we've done so far. So one of the important things that that feeds into all of this work is that the states really do need some feedback to improve their algorithms and look at their cutoff values, and also to focus on the harmonization efforts that I talked to you about. And several states have variable ability to collect follow-up data. So some states have it as part of their mandate, like California has contracts out to their providers, and by getting the money from the state, they need to submit data back to the state about their follow-up and how the children are doing. Other states don't have permission to collect any follow-up data at all. And so it's sort of, that's both ends of the bell curve, and then there's everything in the middle. But states really do need that kind of follow-up information returned to them. There's also this discrepancy between what the feds kind of recommend. Everybody kind of agrees long-term follow-up would be a really good thing to have, and it's recommended, and there's been papers written on it. But then, as I said, some state regulations preclude newborn screening programs from collecting any information. And then when you think about it, there's sort of, what does public health actually need to know to assess harmonization efforts and cutoffs and testing algorithms? And then what does a clinician really want to know from the perspective of how well different kinds of treatment works, how well, what is the proper staging for MRI? Should we change anything as we look at a newborn population? And so there's these different kind of minimum data sets that are required based on what you want to gain from them. And the most important thing is that you need consent from the parents to release information back to states, and even between providers. Obviously, you have to sign a release to release your medical record from one provider to another. And so releasing any kind of information back to the state requires consent from the parents. And this gets complicated even more so when families move, and either move states, move locations out of the country, or change providers. So if a provider is a different person than we actually sent that baby to, our hands are kind of tied to get any kind of feedback. And the other thing that you have to consider, and things that are important to remember, is that families suffer from research weariness. We're all trying to do the right thing. We all want to have projects to kind of look at these factors. But when you keep paying a family over and over again to participate in research studies, they become weary of that. And there's also registry weariness from both a family's perspective and the providers. And we've seen this in some of our other conditions as well, where there may be multiple registries, and some providers solicit to give data to some and not others, or they feel like they want to do the right thing, and they get bogged down in giving data in different formats to different registries. And so at the end of the day, we really want to make sure that we're collecting information and that families are driving the collection and that they're getting something out of it as well, and to have sort of a national ALD registry. And Dr. Orchard talked about this last year in attempting to try and put together a national registry in order to collate this information and have it complete, have as complete a data set as possible. And this will allow us to be able to answer some of these questions. And we can't do it until we have a complete data set. So it was very, last year we were left with this idea of how do states get the information back to the program about how their children are doing without us having to call or having families reach out to providers and that sort of thing. And so the Association of Public Health Laboratories, or APHL, is sort of, in the newborn screening world, they're sort of our honest broker of data. They set up the New Steps platform. They are sort of the go-to place for newborn screening programs across the country, and also all other aspects of public health lab testing. But we have a very good newborn screening group and relationship with them. All the states really contribute, and they help us out a lot. And so they were able to offer some financial and in-kind support to the ALD registry. And it was particularly as it related to these efforts to be able to get parents to consent and give data back so that we can do long-term follow-up in ALD. One of the issues with ALD, as you all know, is this this long-term follow-up piece, that we need that information back. And as I said, our first babies are now 7 years old. So that's what, second graders. And we've been screening all this time to wait for their, to try and track them and make sure that their outcomes are good. And so the registry was actually developed to collect all of this data. And the idea is it will be electronic consent, and it will have both demographic information, much of which newborn screening might already have, but also various lab results. Does the child have serial very long chain fatty acid results? How do they look? That sort of thing. There's hope to have the ability to submit DNA or ongoing samples to do downstream studies as well. The capacity for families to send their children's MRIs. One of the things that was discussed was whether a second opinion could be given on those MRIs, but that requires some legal review, obviously, and liability there. And it allows families to opt in, basically by checking a box to allow the newborn screening program to get that information back. And so this is sort of hopefully a win-win situation for everybody involved. And the outcome will be, we'll be able to have a complete data set when I present these data and not have to put the parenthetic on it. Of course, APHL is all about public health, as are the laboratories. And so we really want to maximize the benefit to public health. And again, this will help us to develop a data set that meets what the state needs, and also in a format the state can use. It'll allow for the transfer of data from the registry back to the program and establish the infrastructure to be able to track the consented families and make sure that we're not getting information from families who don't want us to have it, and we do get information from families who do want us to have it. There could be a predetermined interval to release this information back to the newborn screening programs, and then also to support data extraction from the local sites, because we're interested in making determinations about what the diagnosis is, how it's classified, the phenotype associated with the clinical diagnosis, what is the family history information and laboratory and imaging data. And so having this all in one place will definitely assist everybody, hopefully including the families. So as usual, we always have issues for future discussions. As I said, we're in the process of compiling state-by-state methodologies and algorithms to be able to take a look at cutoff values and be able to investigate maybe some of this variability. Investigate the number of families members that have been diagnosed by newborn. So the newborn is sort of the proband index case, and questions of how far you go back in a family, and how far, what family members you should really test. Is there a way to collate that information as well? And that may be a piece on that registry. Taking a look at whether multiple the mediums could be a useful way to not have a number cutoff, and have the ability to have actually comparative data across the country. Ongoing working case definitions, or public health definition of, encouraging states and providers at least, or states at least, when we're trying to look at this information, to use that single public health definition in new steps. The functional testing and use of red blood cells, and in females to make a diagnosis of ALD. And then ongoing issues around testing female newborns. This is an issue in Europe and in one of our states as well. And what are the implications for older siblings and family members? So this is ongoing discussion as well. And there's identifying carriers. Some countries in Europe are very against kind of identifying potential carriers, but newborns may have a condition just very later in life. And so there's all of those ethical questions as well. Another thing is to just make families aware that there can be environmental triggers, and maybe that warrants additional study as well, to protect kids early on from having an insult that could trigger ALD. And then we all agreed we're looking forward to next year. We're already talking about 2022. So that concludes sort of the discussion that I could glean in the downtime between the end of the meeting and this morning. Thanks again to Elisa and the ALD Alliance for putting this together, for our tech help and Miranda, state programs and international partners that participated, as well as our clinical partners, and also Joe for his a lot of discussions and ongoing efforts intellectually to be able to figure out the best path forward for states that are implementing and states that are already screening for ALD. Also APHL for the funding for the registry and the transfer of the data, and all of the funding in the realm of new disorders and new steps, and helping states onboard ALD and other new conditions. And the CDC also for giving us the funding for the harmonization, to get the harmonization effort started. So thank you, and I will answer any questions.
Thank you so much, Michelle. Just so everyone knows, that's a 3-hour meeting, that newborn screening roundtable. It's a lot of information. So thank you for the time, Michelle, to summarize that in a way, for our clinicians and our families, and couldn't have been more on time. So thank you.